Good afternoon. And on behalf of Outcome, a very warm welcome to this satellite symposium, which is all about managing eye care in hospitals with brilliant outcomes for patients. My name is Christina Jekan, and I head up the market access and tendering function for Outcome Surgical in Europe. And Outcome really is all about the eye and eye care. We really have a unique purpose of making sure we help people see brilliantly. And so bringing that into action is what this session is all about. Good vision is incredibly important to all of us because at one point in our lives, at the very least, we will experience vision impairment, latest in our advanced age. Now, preserving vision and restoring good eyesight as a result is also absolutely critical to healthy aging, and never more so important than now as we're pulling out of the pandemic situation. So if we focus on specifically cataract for this session, cataract is a clouding of the lens that happens naturally with age, and it's completely inevitable. It will happen to all of us if we hit a certain age. Now, the good news is cataract can be effectively treated in surgery, and vision can be very effectively restored as a result. Now, I'll hold this a little further away. Now, with the aging demographic, cataract surgery has become one of the top 3 most frequently performed surgeries in virtually all healthcare systems. It is established to be highly cost-effective, but it also poses a significant burden on public healthcare budgets because it's generally reimbursed across Europe and beyond. Now, with all the volume of cataract care, you would think that the procedure as well as outcomes are pretty much standardized, but not so. Because as you see here, significant variations in outcomes still exist. And these variations create huge impact on patient results, but also on the allocation of resources in healthcare delivery. And there are just 3 examples here I want to run you through. It's starting with waiting lists. Even before the pandemic, waiting times varied by a factor of 8 across European settings for patients. And we know that if a patient waits for more than 6 months for their cataract surgery, they're at much higher risk of falls and vision impairment than not waiting. So there are big costs associated with waiting lists and that variation in waiting lists across Europe, which has only been exacerbated by the pandemic. Another example is intraoperative complications. There's a 4 times variation in capsular complications during surgery, each complication requiring additional hospital visits, additional interventions, and being associated with costs. Post-surgical complications are a 3rd example that is hugely important. The most frequent complication associated with cataract is posterior capsular opacification or secondary cataract, which can happen several months or even several years after the surgery. And it's a renewed clouding of the lens which requires a laser intervention. Now, with a 10 times variation in PCO rates occurring and associated with that YAG laser treatments, again, the cost to healthcare systems associated with that variation is significant. So if we're able to reduce the variations that we see in outcomes, we're able not only to improve the experience and the vision quality of our patients, but we're also able to use resources much more efficiently as a result. So if we talk about what is kind of a joint goal with a patient in mind, for cataract care, it's to ensure the best possible vision outcomes while minimizing avoidable adverse events in the process. But increasingly, it's also about personalizing treatment outcomes for patients who may want to be spectacle independent as well. And these options increasingly exist. So what we're solving for together in this session and beyond is really to find that right balance between delivering an outcomes-based care excellence for our patients in an efficient and sustainable way. And that's what this session is about, to walk through 4 very tangible examples of how we can do that. And we will be starting off talking about embedding outcomes data capture in clinical practice to ensure we work towards best practice care. Then we talk about patient pathway optimization as a way to drive sustainability and improve capacity. We will speak about value-based procurement as a way to embed quality and outcomes consideration also in purchasing processes. And we will round off with talking about financial solutions such as pay-per-procedure models to ensure financial sustainability in eye care. Before I hand over to our distinguished speakers, just a practical word for all of you in the room or online. You can pose questions throughout the session. We will have plenty of time at the end of the presentations for discussions and Q&A. So please activate your Q&A function on the app or on your screen at home, and we look forward to lots of interaction afterwards. Without further ado, I would like to hand over to Professor Lorenzo from Portugal. Professor Lorenzo is the president of the Portuguese Hospital Administrators Association, and he will talk to us about value-based healthcare implementation in Portugal. Professor Lorenzo?
So good afternoon to all of you. It's a pleasure to be among you to present a project that we have going on cataract surgery, and that we want to actually extend it to other vision areas. So I'm the president of the Portuguese Association of Hospital Managers, but actually I'm also a hospital manager at Coimbra University Hospital that actually is the leading partner of the project that I'm going to show you. And that's my beautiful family that was there. That is quite relevant also for being here in Barcelona, and they are there waiting for me at home. So mostly I will talk, and actually we already talked about the importance of, or the relevancy of cataracts as a disease. That actually it's unavoidable for age, and it is a procedure and an area that has been increasing and has a high economic impact all over the world. And again, I will not repeat this, but there are outcomes variations that can be considered a waste in the healthcare system that need to be dealt with. And when we are talking as hospital managers or health economists, this is something that we really need to tackle. One of the points that we know already, even from health economics, is that agents act according to economic incentives that we have in place. And actually money, we can say this, influences the way that agents behave. Another topic is that the outcomes variation can be impacted by the payment models that we have in place. And actually, at some point, even the payment models can be promoting waste, and we need to deal with it. And of course, this idea about the economic incentives driving behavioral change, and we know for sure, at least more broadly, from since 2006, from the Michael Porter's and Elizabeth Theisberg's book, Redefining Healthcare, that we need to move to new ways of payments in the healthcare sector, mostly to apply what we call bundled payments. What are bundled payments? It's actually something that we are paying for the outcomes of our interventions and not for the procedures itself. What Michael Porter would consider some throughputs in the system. So what we want from the healthcare system is not a number of procedures. What we want from the system, in this case, is that our patients recover vision. And that's our main focus. Actually, we started, and currently we have, even from the ISHM, the International Consortium for Outcomes Measurement, have developed a very interesting standard sets that can be applied to different conditions. And even ITF also published this book 3 years ago, this handbook for pioneers, also to help providers to implement what we call high-value care or value-based healthcare. And we use this in our country for cataract surgery. So mostly what we have done is to join different hospitals, public and private hospitals, under a public-private partnership. That actually what we addressed the issue is that we needed to apply value-based healthcare on cataract surgery that would allow us to actually also develop and to incentivize quality, most of it. So this idea about promoting outcomes, where of course we deal with all these issues, where we are promoting also behavioral change, we are promoting the increased quality, and I will show you how we have been doing this. By applying this, actually, we create this learning community where we can benchmark different providers according to the quality of the procedures practices from these different hospitals. With this outcomes transparency, we also are stimulating the active learning of providers, but also practitioners. And also, we are now in a position where, by developing this registry, we can also implement randomized trials. So this was a big step involving different hospitals. Okay, so let's move too fast. Okay, and what we have done, as you can see here, I believe that we're going to get. No, it's not working. Just get the pointer. But mostly, what we start to measure is not only clinical reported outcomes, but also patient reported outcomes measures, what we call PROMs. The application of the standard sets allow us, of course, to address different complexities, different patient risk, and mostly we have addressed the patient reported outcomes measurements by also applying, of course, this questionnaire. But we had also, and one of the issues that we identify is that we have, and how we are going to measure this, and what we have done mostly is with a technological partner, develop a way of using this questionnaire with, that is this company Promptly, that is very easy to use by patients to measure the patient-reported outcomes measurement. What were the challenges that we had? Mostly related with what are the common standards between different hospitals: case mixing, outcomes reporting, disclosure levels, insurance, full coverage of reporting. Actually, we achieve 80% of all patients that were intervened. And this allows us not for the providers to do some sort of cherry picking, so selecting the low complexity patients. We implemented also internal external audits in each site, and we use a common efficient data entry and analysis platform. So this was the challenge and the way that we used to overcome them. And as you can imagine, we are talking about different hospitals, different organizations, private, public hospitals, and as you can imagine, this wasn't so easy to implement and to have all the partners on agreeing on all this, on how to solve all these challenges. Oh, great. So mostly this was our technological partner that we used to measure PROMs. And as you can see, you have this in the web, but also in mobile devices. And we publish at the end different reports. This is from 2020, where you have different reports for practitioners, physicians, of course, and for the general public. And actually, until 2020, this I will be. Hopefully we will have better data at the end of this year, but at this point for this report we ensured more than 11,000 patients in our registry where we have all these standards applied. So all the clinical reported outcomes measurements, but also the patient-reported outcomes measurements. And you can see different achievements from different providers and with different clinical approaches. And I will be glad to share with you all these reports that actually you can also Google them. This project was also awarded by the World Economic Forum as one of the leading projects worldwide on value-based healthcare, and actually it's this global innovation hub. What we have learned from this mostly is that, and this is quite relevant when we are managing teams at the hospitals, is that actually practitioners were quite excited on implementing this. Of course, there is always a cultural barrier to start this, but at the end, everyone is quite energized and happy and on implementing this kind of models. It enabled this idea about benchmarking about different organizations. I don't know what is your experience, but if you ask different surgeons, they will always say that they are the best ones and they work in the best hospital. And in this case, we can really measure what are the hospitals that achieve better results. And of course, also the measurement of PROMs also empower patients in changing all and improving for the hospitals to improve all the patient clinical pathway. And these three learnings are quite important in what we want to achieve next. We need to find another point. So next steps, mostly to expand this project, not only to different hospitals, but also to other diseases on the area of conditions on the area of the vision, but also to improve the benchmarking, to have this idea about the benchmarking of different hospitals that can be shared transparently, not only by the reports that we publish every year, but also in a specific dedicated benchmark. We didn't do in this project, we have in other projects in value-based healthcare, other projects, but not in this one, the time-driven activity-based costing that is relevant, and we are doing it now, but we don't have data at this point. We want also to work with the payers, the public payer, but also the private insurance payers, to define new payment models that will be focused mostly on outcomes. And we want, of course, to evaluate the introduction of new outcomes measures that can be useful for all the clinical pathway. We want also to engage with the industry, mostly because we can also test and work with the industry in new different utilization, different devices, with this objective that we can achieve real-world outcomes measurement. And we want, of course, to increase the scalability of the project, mostly with other hospitals. So if you want to join from different countries to this project, please contact me. What we are doing now, this project led to this project that we also are applying for the Horizon Europe. So mostly what we want in this case with different European hospitals is this extension of this project with other partners. And of course we have other projects. I'd bring this one that we are using in stroke, that is a flagship project from the European Institute of Technology for Health. That actually I bring this one because it's led by our hosts from the Institute Catalán de Salud, that we are also partner, and we want to increase not only in eye care, but to other areas that value-based healthcare can be quite useful. So thank you so much for your time. I will be glad to answer to all your questions and to meet you during the Congress to exchange some ideas and finding ways of developing partnerships. Thank you so much.
Professor Lorenzo, thank you very much for this interesting talk. Up next, I would like to introduce Dr. Luis Castillón, who is the head of ophthalmology at the Hospital San Juan de Dios in Seville. And Dr. Castillón will talk to us about a project around patient pathway optimization in cataract care. Over to you.
Thank you very much, Christina. And we do really appreciate this very kind invitation by Alcom and by yourself, Christina, because we would like to give you the clinical point of view, which is not the whole point of it, but we'll try to give you the clinical point of view and the patient point of view of everything that you are doing. So we're starting saying, I'm afraid this, okay. Let's go back. Yes, we do have a big problem. All of us have it. And believe it or not, this is going to be even worse in the next coming years. We have a pathology that is so frequent and is going to be even more. And we need resources that, as you know, healthcare resources are going down, and even more in the COVID situation. So here we have a problem. We all have a problem. Believe it or not, this problem, I believe it'll take a great amount of work to do surgery of cataract surgery in a Komodo's dragon, but you have to believe me, it's going to be much more difficult to face this problem because the cataract is the leading cause of blindness all over the world, of course, with differences between countries, but is, like Christina before said, one of the most frequent surgical procedures, and it's very expensive also, but this is the clinical point of view. It gives allows people to see brilliantly. So it's something we have to be aware that we need to protect and we need to go on doing it. But how are we going to do it? And say that we are doing a lot of surgeries every year, that COVID impact has been terrible, that the condition of priority is still, but we've been through an increasing on the waiting time in order to go through surgery, an increasing of the surgical problems, as you have seen before. And it'll be worse, as I say, because all the baby boomers, those who were born like myself in the 1960s or in the 1970s, maybe in the next 15 years we will be needing also a cataract surgery. How are we going to face it? How are we going to do it? And who are we? We work in a hospital in the south of Spain, in Seville. We provide public health care to a population of 300,000 persons, and we are 12 ophthalmologists that we do perform around 250 to 300 cataracts every single month of the year. And what are we trying to do? What I'm going to explain to you, in trying to do it in an easy way, we are trying to face this increasing demand for cataract surgery, but also, like Professor Lorenzo said, setting a set of KPIs that allows us to say we are registering, we know the outcomes, we don't just know the numbers, 250, 300, what the difference does it make? What really makes the difference is knowing what are the outcomes of the patients that are going through surgery. And how have we done it? Then we look for a partnership with Alcon. We found Alcon that, as you all know, is a well-known leader in ophthalmology with a very well-known expertise in cataract surgery processes. And what we have done is we've done a structured methodology analyzing the pathway. And we have gone through identifying assessment, then proposing changes, implementing them, and then going back again and doing some follow-up and see if what we are doing is right. What exactly I'm talking about? We started into 2019, and I thought that we were doing it perfectly. As a matter of fact, I was always saying, we do it right. We had 2 surgery rooms with 6 cataract procedures, but as soon as we commenced to analyze, we found out that the satisfaction of the patients with the surgical procedure was not very good. And also, the satisfaction of the staff was not always good. And we've come, after doing the analysis that I will explain soon, we've come to the 2021 with the same 2 theater rooms, but doing more surgeries, 18 in each one, but believe it or not, with an improved staff satisfaction and with an improved patient satisfaction. We also got powerful, and we went to another hospital and do the waiting list and increase the number. which I will explain later also. We did this after analyzing with very minor changes, like furniture changes, like changes in the pathway when we have to go to breakfast, or what were the changing rooms. Because what we did is we went through all the track that a single patient had to do when he goes to the hospital to go through a surgery of cataracts. And it goes from patient registration to patient check, and how we do the dilation of the pupil, or how many times is the recovery or the discharge. And we just started to point some red flags. Those were the places that we had to change in order to improve our methodology. And then we did the changes that I just called, very minor changes in the pathway where we have found we had the problems, and believe it or not, the situation changed dramatically. This slide is very important. Like, if you ask any clinician like myself, what is the most important thing in the day of the surgery? The surgeon? Yes, of course, and the surgery. But this is only one place, and this is only 16 minutes out of the 3 hours and 40 minutes that it takes the whole procedure. And we have valuable time, which is the time when we're doing something on the patient, registration or cleaning the room or pupil dilation, but we have non-valuable time that we found it was not useful, and it was expensive, and it was paying in order to increase the number of the surgeries. What we've done is we've come to this slide in 2019 to this slide in 2021, where we have changed, decreasing dramatically the number of minutes in the non-valuable time, and increasing the staff satisfaction and the patient satisfaction. But also, as you can see, the surgery time, it was almost the same. The most important thing of the day, it remains the same. This is pseudo to resume of it. We increased the number of cataract by 33%. We had a reducing waiting time in the day that you go through surgery of a 75%, with a sharp decrease of time in non-valuable added steps and total patient time. This is critical because cataract is a surgery that is very, I don't know if this word exists in English, is very standardized. Everyone should go the same time in the same places, and that doesn't happen in most of the theater rooms that you know all over the world. If you see the patient that had the number 6 or 7 in the turn in the list of the surgical of every day, was the one that had to wait more, and that was because of the breakfast time of the administration staff, believe it or not, and that was very easy to solve. You can see upwards in blue was 2019, and downwards what we solved in 2021. The pupil dilation time, that's very important because we need the pupil to be dilated. If not, the surgery is much more difficult. And before, we spent only 5-10 minutes because we have to rush to go to the surgery room. And the surgeon was very unsatisfied, and the patient, many complications that we do not have or that we are planning not to have right now. So those changes have an impact on the patient satisfaction and on the clinician satisfaction. This is not always symmetric and sometimes have turned a little worse, but mainly we've come better with all the track. We have done in a different place. Let's say we have learned how to do it, so let us do it in a waiting list, in a different hospital, and go up to 10 or 12 surgeries, one surgeon, one theater. This is very difficult. I don't know yet if we're going to keep it too long, but right now it's working like that. Many differences. This is a hospital only for ophthalmologists, and the payment, like Lorenzo said, is different. Every single professional gets paid differently for each one of the procedures. That makes the people an interest in doing more in the same room. But it is 12, it is more efficient than is the other one. This is what I should be speaking to you next year, and this is something that it keeps me awake all night. We need to implement a standard cataract data set. We need to have knowledge. What are the outcomes, the clinician outcomes? How is their vision after doing so many surgeries? How many complications? Even like Professor Lorenzo said, which of the surgeons in my team has the worst valence of complications? And this is not to punish, but to do it better so we have less complications. This is a total change of mind. We're not going to speak anymore next year of we do 250 cataracts, but we are going to talk about this is the gain in vision, this is a rate of complication, and we even know it is the same in Institute Karolinska of Sweden, or it is the same in Portugal. This is amazing, but we're crossing those data with the sensation of the experience of the patients. What are we doing now? We are not just doctors doing our job, but we are listening what the patient wants to know. So I think this is the change. I think this will come, and everyone should be like, the duty is to do this register of the data in order to have outcomes that are all over the world and we can share. Thank you very much.
Thank you, Dr. Castillón, for this inspiring talk. Now, up next, we have a virtual panelist joining us. So it's Johanna Öberg, and I hope we're able to project and link her to the audience. Are we able to connect Johanna into the room?
I can hear you. Can you hear and see me?
So still waiting. But Johanna Öberg is the Chief Executive Officer of Mimira Eye Center in Sweden. And Mimira also is all about eye care in a private network of hospitals. And Mrs. Öberg will be speaking about building the future eye care by investing in customer experience, digitalization, and patient satisfaction. And a very warm welcome virtually to the room, Johanna.
Muchas gracias. Buenas tardes, Barcelona. I can tell you that considering that here up in the dark north, the first snow was welcome this morning, I would have very much liked to be with you all. But unfortunately, I couldn't. So I hope this works. Can you see and hear me well?
Can you give us 1 second, Johanna? I think the sound quality is not yet very strong. Are you able to increase the volume?
I have my volume on full, and when we tested it, it worked well.
I'm talking to our technical team here in the room. If you say one more sentence, Johanna, maybe we test again.
Yes, testing. Can you hear me?
Much better. Okay.
All right.
I think we're all set to go.
Perfect. And you can also see me, right?
Yes.
Good. Then we're good to go. As I was saying, I welcome this day up here in the dark north with the year's first snow. So I would very much have liked to be with you in Barcelona, but unfortunately I couldn't make it, but I hope this will do. I am the CEO of the Mimira Eye Center, which is, there we go, Scandinavia's largest player within refractive surgery. Thank you very much to the two previous speakers, very interesting. What I will be talking about is how customer experience at the core of our offering creates the highest patient satisfaction and the best clinical outcome. And I think that I come from a slightly different perspective than the two previous speakers, because 75% of our business comes from private pay. And that creates somewhat a different playing field for, now I'm trying to change the, have you given me control over the, thank you. And that creates a slightly different playing field. And I think we relate to our patients as patient only one day. That's on surgery day, and the rest of the journey with us, they are customers. Very shortly about Memira, we are, as I said, Nordic's largest refractive player. We have business in Norway, Sweden, Denmark, and as of recently, when we were acquired by Dutch Bergman Clinics, we also operate 7 clinics in the Netherlands. We have, as I said, refractive private pay at the core. And I think that from our perspective, that creates, now I have a problem again with, have you given me the control? Thank you very much. As you see, we in Scandinavia, 63% of our customers are IOL customers. There we go. Private IOL customers, which represent roughly 18,000 refractive IOLs. And including Netherlands and Scandinavia, we do roughly above 30,000 cataract IOLs yearly. Can you go? Now it seems that I have control. Thank you very much. Sorry about that. Again, customer acquisition is at the core of our business. We have a quite challenging business model, being private pay and a non-recurring business model. So we have invested a lot in customer experience, both digitally and physically. Digitally, it's all about investing in marketing automation, online customer journey, continuous A/B testing on what content works best at acquiring customers at every given moment. And we focus a lot on data and analytics to be able to continuously and constantly improve our customer experience in the customer journey. We took a broader perspective on this when started working with service design. And service design is basically understanding what defines the signature moments for our customers in their customer journey with Memira. Certain moments are signature moments that really need to be outstanding. Other touch points in the customer journey can be good enough, and it doesn't really change the perception and perspective of the clients. So we have studied quite closely what exactly are the most important and defining moments for our customers. And that's where we have invested heavily, both digitally and physically, as I said. We've also seen that having a fantastic customer journey, IRL, is obviously the most important thing. But expectation of that IRL moment are built up on the digital customer journey. And that's why we have invested heavily in building customer value, making sure that the operational efficiency is at best at all time. And that also creates an opportunity for us to constantly adapt to new business models. We have seen that with an organization that agilely can develop a digital roadmap that is aligned with our business goals and business model, that will create a step forward in front of our competitors, and also make sure that we live up to the expectations that customers have these days. Because regardless if you're a patient or customer in ophthalmology or in any other service or business, you have high expectations on what you will meet from a digital perspective. And when we saw that we weren't really living up to those digital expectations of our customers, that's where we started to invest in a very transformative program that we call Digital Platform 360. And this is not at all only about making sure that the underlying compliance is there within EMR. This is a complete new system where we move towards web applications, both in CRM, EMR, analytics, to make sure that we can connect equipment with our core systems. It's about data and data and data. We are obsessed about measuring our customers, both what they experience during their customer journey and obviously the patient outcome. As I said, we are really investing in a state-of-the-art system platform to be able to take our business to the next step when it comes to digital steps in ophthalmology. And here connectivity is key. Connectivity and interoperability, because with open APIs and interoperability, we can create chains of services between different caregivers and through the entire pathway of a patient. We are looking heavily into AI-based image recognition, and that will mean that non-specialists can assist in care deliveries to both lower costs and to cover a more broader geographical space, which is much needed up here in Sweden and Norway, where there is vast land to cover between ours, around 60 clinics. And in this collaboration, knowledge transfer between, not only within the system and within our company, but also between all our different partners across this pathway is extremely important. Again, coming back to what is my mantra, we have a private pay customer. We have to deliver not only the best clinical outcome, but also the highest patient satisfaction. We have 10 plus years of data series in Net Promoter Scores. We have Net Promoter Scores per clinic, per optometrist, per doctor, and we monitor this monthly, and then we implement personal improvement plans for each of those categories. And NPS is one of the most important criteria for us in our procurement processes. The scorecard at the right is the scorecard that we used when we just recently performed a 9-month-long procurement process to choose our partner in IOLs, both the cataract IOLs and refractive IOLs. And the combination of clinical criteria, patient satisfaction, obviously commercial criteria, and making sure that our partner, which ended up becoming Alcon, can provide best in class all along that that measurement journey. And what we think is extremely important is that we work with partners who can really become not only suppliers, but a true partner at the core. And we need simplicity. We need a very streamlined process, and we need to be able to standardize because we have surgeons and doctors working all across these 67 clinics. And we have to make sure that it has not only the highest standard in all the supplies that we use, but also the most efficient way of handling those supplies. That creates the best clinical outcome. That creates, as we could see in the slide before, the highest NPS, which we found with Alcon, and that creates, obviously, the smoothest and best experience for us as a company. So going from a very scattered structure to the paper procedure structure together with Alcon, that really made us take that leap from working with a supplier to really becoming a partner and improving towards a better both patient satisfaction and customer satisfaction at the end. So to sum up, customer experience at the core will force you to invest in digitalization, will force you to focus on patient satisfaction, and the use of quantitative data, not only for clinical outcome, but also for customer experience and for customer journey and the different touch points. That is what we see as the core of our business. And those parameters are really at the core of our corporate culture. And that's how we plan to continue to build a very successful future eye care business. Thank you very much.
Thank you so much, Johanna. And thank you also for navigating those technological glitches we had at the beginning. Please stay with us for the question and answer. I'm sure there'll be lots of comments and questions coming your way and everyone's way as well. So to wrap up our panel session, I would like to introduce Mr. Brian Mangan. Brian is a procurement expert and leader in the NHS in the UK. He's the managing director at Brian Mangan Associates, and he will be talking about value-based procurement, a stepping stone towards improved outcomes and lower costs in healthcare. Thank you, Brian.
Thank you very much. Afternoon, everyone. Hope you're all safe and well. I'll be taking a slightly different tack on my presentation. It's going to be more around looking at actually value-based procurement. Sorry about that. It's more about value-based procurement as opposed to value-based healthcare. So, of course, next 15, 20 minutes or so, just want to walk you through and give you an idea about value-based procurement, why is it necessary, and what's it all about. Value-based procurement, putting the theory into practice. I've been leading a project in the NHS now for the last couple of years. So really trying to tell you how we're moving it forward, show you some of the challenges and some of the opportunities. And then what I'd like to do is be able to leave you with something practical that you can actually take away and maybe use in your own organisations if it's something that you're interested in looking at. So I suppose the first question is, why are we doing it? Why do we need to look at value-based procurement? Well, so I've been a buyer now for over 20 years, and this is something, this diagram here is what I've come to know and love. It's my procurement cycle of doom. Because literally what happens is every year you get an annual savings target. Typically in the UK and hospital, it will be £1 million to £1.5 million. You go out, you produce your work plans, you look at your frameworks, and then our favourite bit as buyers, we have the pleasure of challenging suppliers while trying to get the price of the products down. And I think we're pretty good at it. We are. Over the years, we've seen prices go down across the board. I did a lot of work in orthopedics. We've seen a reduction in 50%. Over the last sort of 10 years. And even in ophthalmology, I think it's about 30% that we've seen in the last half a dozen years. And I think for me, one of the big challenges is that, you know, again, because we are so effective at it, is as much as we want things for free, because that's what buyers are like, we can't get it. So where do we go? We've got massive challenges in the system in terms of increased demand for healthcare. We know there's increasing demand literally across every country in the world. So just by focusing on the price of the product, are we actually going to contribute as a profession? Are we actually going to make a difference to the health systems that we look after, that we support going forward? The answer is probably no, just by focusing on the price of the product. The next thing is obviously COVID, and we've heard from my esteemed colleagues here today, the challenges that we faced in the health system. You know, we've got people literally, the English love to queue, and the people are queuing up to get into the hospital to get cataract surgery. It's massive. So again, just by focusing on the price of the product, are we actually helping in alleviating the challenges within that? And then another area, I think it's typical of what's happening across Europe, is that we're moving to what we call integrated care systems. So again, when I used to work in a hospital, it wouldn't, you know, for me, I was just really purely interested in what was happening in my environment. So potentially it could mean going forward, as we look to integrated care systems that bring in acute hospitals, community and social care, that a cost will be incurred in an acute hospital, but it will actually have a far better impact, lower that and reducing costs across the whole healthcare economy. So these are just a few reasons why I believe that we need to change. So what is VBP? Well, it's not rocket science. What it is, it's a holistic way of looking at procurement. It's one where procurements are given the scope and freedom to have procurement savings and efficiency targets, where they then work closely with clinicians to identify across the pathway what needs to change and by how much. And then we work with our colleagues, our supply colleagues, and say, this is what we need to change. Have you got the capacity and the capability to actually do it? And then when we go out, we don't just focus on the price of the product. We apply box standard, most economically advantageous tendering. So we're looking and say, okay, we might have an increase in the product, but it's going to reduce the cost of the pathway. And then the final part of the journey we're on, and it's already been mentioned before, is that we have traditionally adversarial relations with suppliers. And particularly in the UK, we let and forget. We let a contract, and the next time we'll have a conversation with the supplier will be in about the March time when we're asking them for a reduction in the price of the product. And it's not about that. It's about working in partnership with suppliers going forward to use their expertise, their network, some of the things that other customers are doing to try and drive value continually through the life of the contract. When I started working for the NHS a couple of years ago, looking at the pilot project we were doing, we came up with the definition. And I've got it on screen now, and to me, it does feel a bit wordy. But there are a couple of key things within that. And one is that it's a strategic approach. It's not a tactical approach. It requires a strategic change in direction to the way procurement operates, the way suppliers operate, and also the way that we operate together as a health system. But it has to deliver tangible and measurable benefits. And I make no apologies if I mention tangible and measurable about 20 times in the course of this presentation, because that's what it's got to do. It's got to deliver some benefits. And it's not just about focusing on the one element of tendering for procurement. It's looking at supplier relationship management, contract management, and so on. So see, for me, with hindsight, it probably does need developing a bit more, but it gives you a view about where we're coming from with value-based procurement. So when it comes to the project, I started it back in 2019, and I was asked by the chief exec of NHS supply chain. He said, we get suppliers coming in, and they often say, we've got value, we want to sell you value, we want you to run a proof of concept project to see whether it actually does or not. Quite challenging timescales. We had to deliver between 15 and 20 projects. The projects that were selected had to actually make a difference between 3 to 6 months. It was all really short-term stuff. None of the outcomes, it's all about pathways. What we ended up with 27 proposals that we got from suppliers, and we culled that down to 13. And a mixture of COVID and a couple of projects didn't deliver what they were going to. We ended up with 8 pilot projects that we ran. And what we found is the value was created across 5 main areas. From something as basic as you pay a bit more, but you use less of it, a reduction in consumption. We had 3 projects where the technology allowed people to have move from an inpatient to a day case. Real massive benefits for for the patient and releasing capacity as well. Another one allowing people to have their antibiotics at home. And we had one that was a capital project, which enabled transnasal endoscopy. It was better for the patients. It was quicker. You know, the whole thing really improved the patient's experience. And then the final two we had was around reducing infections or reintervention. I think that's a critical one. I was talking to an ex-chief exec the other day about the situation and value-based procurement, and he said to me, 3 key things. We want to try and keep it out of the hospital. When they're in, we want to get them out as fast as we can, and we want to stop them coming back in. And I think they're sort of the 3 areas that really we need to focus on. But what I found was the value, if you like, was created across 4 areas, 4 generic areas. If we'd focused just on price, we'd have a financial benefit, albeit a modest one. Well, here we've got efficiency, we've got patient benefits. Some of those inpatient today case solutions, they were quite brutal. The original where they were in theatres for an hour and a half. This was 20-minute procedure out the same day. You know, and environmental as well. So again, we're using less resources in order to do the procedures that we're taking on. So it was a good project. There's some case studies that are going to be published, and I'll find a way to get them get a link to share with you, so you can go on there and see practically what's actually been delivered. So I think the crux of it for me is that, you know, focusing on products, it is short term. It's not going to last forever. And I think there's a real recognition in that around procurement departments, finance, and other people that I work with. So if you get 10% off the price of an IOL, you might get yourself €10. But when you think about it, the cost of the actual product itself is minimal. It's minimal in terms of the costs that are in the pathway. So if you looked at the pathway, potentially you could get nearly €100 just by focusing and saying, we're looking at the wrong thing. We need to take the thing as a total cost. There are challenges within VBP. It's hard to recognise value. The first one is about the systems that you work in. We've obviously got some enlightened systems in the cultures that we've heard from today, but a lot of them are based on literally 12 months product price, get the price down. And I think that this is really an area that we need to work on, and it's not impossible to do. Since the work I've been doing with NHS supply chain, we've managed to get engagement from the system leaders to really start looking at it. I think that's critical. The other one is about, I told you before, about making it tangible. So one of the pilots that I looked at a while ago, we had a supplier that came in and said, I can save you 3 minutes in theatres, and it will save you £2 million. And that wouldn't work. There has to be something tangible. I think I was quite disingenuous to the supplier, but I think with hindsight, if I'd gone back and said, if you can save me 30 minutes, I can do something with it. And it's about us being able to specify, the health system being able to specify to the suppliers what that tangible difference is needed. And then the other thing is it has to be attributable. Now, again, I've been given a copy of the NOD report, and I looked at that. I've got a clinical background. I ran through it, and to me, there does seem to be a correlation between the type of material that's used to reduction in PCO rates. Don't test me on PCO rates, but there does seem to be a correlation between that. And what I'm saying is that if you're going to pay something, if you're going to pay more for a product, then it has to be a direct relationship between the introduction of the product and the benefit that's delivered. And then the final bit is you've got to be able to measure it. And I'm a fairly simple bloke. You might have gathered that by the time I've been standing up here. I think it's about focus on literally like 20% of the measures will probably drive 80% of the value. So it's about keeping it simple. You know, we have systems in hospitals that you can tap into, and that for me is what you need to do with that. So I suppose, sort of to wrap this up, it's where do you start? I think the first one is that it's engaging with clinicians. It's engaged. I've always talked, when I talk to clinicians about VBP, value-based procurement, it's like pushing on an open door. They can see you're trying to get them the best outcome, the best product. It's not just about getting them something cheap. And I think it's about working with them to map out the processes that we've already found, we saw before, and seeing what needs to change, by how much, and can you support us in delivering that to create this tangible benefit. It's about targets. And I'd ask anyone in the audience who's got any influence at all within the system, talk to the system leaders, talk to the people in your organisation and get them to become enlightened, get them to see the bigger picture. Because it is there, to me, it's kind of blindingly obvious. There was something that was put on LinkedIn for a report that I'd written recently, and they had hashtag makes sense. And for me, that kind of summed it up. It isn't rocket science, it's just a sensible approach to take forward. The other one is about assurance. So what the health systems need from suppliers in terms of assurance, is it evidence? Or is it something that requires more like a monetary thing about saying, okay, we believe that it will deliver this level of benefit for you, and we are prepared to underwrite to in some financial way, but it's all down to your own systems about what that entails. But my experience from talking to finance directors in the UK was that would be an incentive for them, because VBP is a leap of faith. It's something different. And if they got that safety net, that things can be delivered and there's nothing to lose, I think you'll find you get a lot more traction from there. The other bit is we manage people. I've managed people probably in your own environment. And, you know, McGregor, one of the management gurus from many years ago, you have theory X and theory Y. A theory X manager looks at people as being inherently lazy and all the rest of it. A theory Y manager looks at people that are there, that you need to encourage them to do a job. They're there to make a positive contribution. And I feel that we as procurers in health systems and us as health systems have a very kind of adversarial view on the way that we deal with suppliers. And it's trying to work out, are you a theory X type of buyer or are you a theory Y? And it's about building relationships with suppliers and seeing them as part of the solution and not the cause of the problem. And then so the final bit is the terminology. It's about creating this common understanding of value. I had a conversation at lunchtime. Value is a really strange word. It means probably, if you took it in isolation, it would probably mean a different thing to every person in the room. And as a health system, we need to be very, very clear on what value means. And that way, suppliers can react accordingly and it will benefit everybody. So the final thing is, it's not easy. I've been looking at value-based procurement now for the best part of 6 years. It's great we're moving forward. I think there's beginning to get a lot of traction. And it isn't about the strongest or the most intelligent, it's how we adapt to it moving forward. And I do believe that for me, VBP is a really good solution to the challenges that we face. And that's it. Thank you very much. You've got the details on there.
Thank you very much, Brian. And thank you all. I hope you have lots of questions. Please send them through on the Q&A chat. But to wrap up this, the presentation part of our symposium, we started off really identifying that in cataract care in particular, there's still unacceptable outcomes variations and inefficiencies that are unaffordable at a time when we really need to increase capacity and treat patients well in a timely manner. Now, what our speakers very eloquently spoke to was the great opportunity that exists around the systematic capturing of patient-reported and clinical outcomes to really, in a timely manner, measure, benchmark, analyze what really drives the best outcomes and keep migrating clinical care towards that best practice that we see in the data. If we do that well, not only will we generate consistently better patient outcomes, but also release resources that can be deployed much better elsewhere as well. So it's an efficient solution and a sustainable solution too. We also talked about the importance of analyzing the patient flow and patient pathway, because any improvements we're able to generate in terms of efficiency for the patient often translate also into a much better patient and clinical staff experience. It becomes much more predictable with more predictable outcomes as a result. And we've looked at that if we give the patient a voice, the patient is much more engaged as well in the treatment choices and the goals. And we see satisfaction scores as an important measure in that regard, as well as Johanna very eloquently spoke to. And we also saw that if we work together in an effective way across, hospital management, payers, clinical staff, technology suppliers, and the patient, we can come up with really important partnership and collaborative solutions also around financing and funding modalities that make a much more value-based and patient-centric care possible. So with that, I would really like to open this up for comments and questions to the panel. And we've received a couple of questions from the audience already, so maybe I'll kick off with those. And as I said, please keep them coming. So one of the key challenges always seems to be the, setting up the right financial incentives to really embed patient-centric and outcomes-based care models. So this question, is maybe initially to you, Professor Lorenzo. So how do we make sure that we break through the reluctance to align financial incentives with value-based care?
Actually, thank you so much for that interesting question. First of all, we need to understand that this kind of change, what we call institutional change, has two main factors. One is the endogenous factors, also exogenous. And every payment models are exogenous to the organization. And of course, they are economic incentives to change the way that we provide care. But what we started, and I believe from the clinician side, from the provider side, is that we need to start doing it to promote the change from the payer and not waiting for the payer to tell us what they are going to do. So I believe from the clinician side, it's quite relevant to start to implement clinical reported outcomes measurements, patient-reported outcomes measurements, so that we can influence the payer to move in that direction. I would say that is, and I was even listening to my colleagues, this is not only an issue of payment models. This is an issue about moving from a dumb healthcare system, where we focus on volume, to a smart healthcare system. Even I was listening to the conference from the last speaker, and it's mostly regarding procurement. It's a little bit absurd when we are buying things only based on the low cost. That is quite dumb. And actually, in our daily lives, we don't do it. But in healthcare and even in eye care, we do it. So it's moving for quality and implementing measures that will provide better clinical outcomes and better patient experience. So in this sense, I'm just focusing in your question, I really believe that it's also up to you from the provider side to move forward. You have a problem in this operating room. But actually, this is the movement that we need to address. And I believe that from the provider side, from the clinician sides, they need to lead this movement and not only to wait from the payers. We need to influence payers to go in this direction.
Thank you. Brian, anything to add with regard to the procurement as a payer, to really look at total cost of delivering that care and breaking through different budget silos that are sitting in different parts of the hospital or the healthcare system into a holistic view of most cost-effective care delivery?
Yeah,
how does that happen?
Yeah, I think again in the UK we're beginning to move to these integrated care systems. So there's an example in Manchester where they've devolved, I think it's £6 billion to the health economy. So that allows them now to move away from any silo. So you're looking at the whole health economy as a solution, if you like. I think that's critical. I think if you're looking, again, it kind of what goes back to what I mentioned before. A lot of this is just common sense, really. It's about looking at, you focus on the product. It's not really going to do it for you. You need to focus on the whole pathway and get an understanding of it. And then if you've got a contract for it, it's just being very, very clear about if you change one part of the system, what's the impact somewhere else, and can you measure it, can you report it? Because when you're getting into any contracting kind of scenario, you need to be able to agree. You've got to have that clarity, if you like, of what's been affected and how it's been delivered as well. Would be a view.
No, thank you. And actually, can we get Johanna back also on the screen? for her to participate more actively into this panel. Because Johanna, I guess the question to you, if you can still hear us, you know, in your model, the patient is the payer, and it's probably the purest way of looking at, you know, are we able to position and communicate and measure the relevant treatment outcomes that matter most to the patient, to allocate the right amount of money towards the intervention.
I think there's an additional element when we have a private payer in refractive surgery, because our biggest competitor is actually not doing refractive surgery at all. So our biggest hurdle or barrier is actually not the finances, but the fear. So we have to work very, very hard to take out those barriers of fear until we get to the financial discussion with our customers. And interestingly enough, we see that to see clearly is often it's often priceless. So price elasticity is extremely high, and people really are willing to pay to see clearly, and specifically in the IOL demographics, whereas we see a different structure somewhat in the laser segment, because those are typically younger with typically a lower disposable income. So for us, finances is an issue, but fear is a bigger one.
Mm-hmm. That's an interesting one. Another question that has come in, and maybe Johanna, a different follow-up, and then we make the round here as well on that, is how do we make sure, if we measure patient outcomes consistently, that our clinical staff or the clinical setup, that we don't cherry pick low-risk patients to make sure the results look good, and that there's a proper risk balance in everything we do.
Interesting question, and I think as commercially skewed as we might look, as clinically focused are we, and we have not seen that as an issue, and I think clinical views will always sort of trump over commercial aspects, and I also think that we have around plus 12 years of NPS scores and patient data, and as I said, we do not only measure everything, we share all our patient data also online, so you can just log into our websites if you understand Swedish, Norwegian, or Danish, that is, and look at our patient data. So we are very confident in our outcomes and in our measurements, in our procedures. So we don't see that there is a risk of lowering patient outcome, and we do not get into that cherry picking challenge.
Thank you. Dr. Castillón, let me pass the question in a slightly different way. Do you see, in terms of measuring pathway efficiency or patient outcomes, how do the full care teams embrace the topic of measurement, and what to you is a big success factor in ensuring that it's fully accepted and integrated into care?
Yeah, very good question. I was listening carefully to my colleague Brian, and he said most of the things we have to do are common sense, but common sense is the less common sense at all. We don't use it too much, so we have to start with that and just leading the point that what are we trying to do with all these changes, because not one person in my team did like the change. Not at all. They don't want to change because they thought, as I did, that we were doing things perfectly before. So you have to explain that. And then it is never bad to have some registration of your data, your own data, meaning. So when we appeal to recognition, not money that you said as an incentive, but recognition and having to know what you as a professional are doing to your patients, then all of them agree with that. They would like to know how they are doing. What are the visions of their patients like? So it's sort of some professional, I don't know to say this, but in requirement. And this is difficult because they want to know themselves, but they at the beginning don't want to know everybody else. So we have to keep secret on there. They will have to know, they will know how they are doing comparing with the rest of the team, comparing with the best one and with the media. But they know themselves, but the other ones don't know how it's hit. I think at the beginning, this is a good solution that when the time goes by, it'll be easier and very well understood by everyone. But at the beginning, changes are not well understood. And yes, I do think it is a risk. So you have to explain very much changes you're doing with a common sense. And then you have to keep secret, delicate data, I should say.
Yes. No, thank you. Thank you very much. Let me pass the question also for Health Cluster Portugal. You have 13 centers with very different private and public setups, all rallied around one common data set capture. What made the biggest difference in motivating everyone to join up to the effort and be part of that joint measurement and analytics?
That's quite interesting. Actually, we have private hospitals, as you know, public hospitals. We have different payers, so even insurance or even private patients that pay out of pocket, and also the public payer. So what I believe is that there is a clinical drive in all the process, and this project was really driven by clinicians. I believe that there is an ethical issue here that needs to be also mentioned. That is, it's not only an economic issue when we are talking about waste, but is an ethical issue to provide the best care available. And in this sense, it was also the community of ophthalmologists that understood that they need to move forward. Actually, it's not only comparing within the team, but also with other providers, not in a sense that we are going to penalize the ones that are the worst in class, but we are going to learn from the best in class. And this idea about building a learning community within clinicians, where we also publish all the patient outcomes, not patient data, the outcomes. But that is quite important to improve the way that we provide care. I believe that this is quite complex. There was a change management issue here. I believe that this is going to increase, the complexity will increase in the future, because even in cataract surgery, it's not only the specificity of the hospital, but we are talking about a long clinical pathway, even to patient's own. It's not only a measure of the surgery, but we will continue. And actually, even when we are talking about the value-based procurement, it's not the lens that we are going to use in that time, because probably all of them will work. It's what we are going to get in 2 years, in 3 years, 4 years. And at some point, hospitals, we forget that we focus on the surgery and we forget what is outcomes in 2 years. Mm-hmm. So I really believe that this, and I believe that our clinicians understood this. Very, very interesting. And I need to praise them. I need to praise them, their will of doing this. And if there are some ophthalmologists here in the table to join us on this movement, because I really believe that this can change, as I was saying in my previous intervention, to move from a dumb healthcare system to a smart healthcare system.
Thank you. Well, we've had one question that goes directly to what role would hospital management or can hospital management effectively play in embedding a value-based mindset? And now you've put your mask just back on. Maybe I'll switch to Joanna first, and then you're back up. Joanna, what would you say about the role of hospital management in particular in embedding a culture around value?
Well, I think it starts as all types of management. It starts with explaining the why, because as someone previous speaker said, people are reluctant to change generally, and not only understanding the why to change, but also understanding what's in it for me. And I think from a hospital management or clinic management system, we're up against, not only in hospital or clinic management, in all types of change, we're up against, this is the way it's always been done, so and it works quite well, so why change? And then clearly explaining not only why this is better for the patient and for the outcome, or not only explaining why this is more important and better for the company, but also for that particular individual and that particular team in that division in the clinic or in the hospital. That's, at least for me, that's the most important part of any type of management.
Thank you.
Just to continue, it's that actually for the manager, even the head of the ophthalmology department, I believe that there is here a process of sense making, so to convince everyone that this is the way to move forward. From management side, we face that, is that we will have always an increased costs in the beginning. We need some investment on these areas. In our case, for example, we knew that we couldn't measure patient-reported outcomes with someone making inquiries or a nurse only at the end or phone calling the patient. So we needed to have this technological partner where we would facilitate the way that patients report their outcomes and other issues. Actually, this increase is mostly the workload of clinicians. So we need to understand that this is not a neutral change. We will need to invest. What I believe is also that at the end, we need also to understand that this is movement is not something that is going to stop. And as even in a competitive market, we know that some of the, and even in our case, we knew that some hospitals would move that direction. So if you are not going to do it, you are going to lose, even in a competitive market. So someone is going to do it. It's better to come, well, everyone as a group to do it, or we are going to allow that one or two providers to do it. So in this sense, I believe that there are several issues that actually they need to be studied. But again, just to come to the beginning, from the manager side and the clinical manager, the CEO, there is a sense making for the overall organization, for all the healthcare personnel that needs to be done. And in this kind of conferences, for example, is something that we start to understand that this movement and to understand the importance of this change.
Thank you. And I like the perspective of projecting ourselves a few years forward of what the expectations are. So one follow-up question, Dr. Castillón, how do you expect the patient expectations about, the surgery, surgical experience and surgical outcomes to change over time?
For better, I think so. And I'm sure of that. We are in a point where we don't really know much about their experience. So everything from now till 2 years will be better than today. And I expect also to be better, because when we will cross our clinical expectations, results, our outcomes, with the clinical expectations of the patient's outcomes, then we will find some ones that do not match. Some sort of patients, 10%, 15% or so, that we believe they will have to be very happy, and they come into our office saying, I'm not happy. And we don't really understand what's happening. And that is not frequent, but that occurs in our surgical treatments in cataract and also in refractive surgery. And as soon as we can cross data and use artificial intelligence or human intelligence to analyze those data, we will know what sort of patients don't get well. And we will have to either make some measurements to understand what anatomical thing is happening there, or either just tell those persons you are not a person that should go through this surgery. So this is a very good point, and I think that will happen in 2 years.
Mm-hmm. And if I may add to that, I also think
keeps pushing.
Yes.
Yeah.
Yes, no, exactly. And Johanna, please go ahead. Yes.
Yeah, if I may add to that, I also think that the cataract patient pool is becoming increasingly healthy, active, well-informed, hence will become even more demanding, and to a much greater extent will request a better outcome. Hence, the demand for premium lenses will increase.
Thank you. And we're coming up against our time. So one final question openly to the panel is, if we were to project ourselves forward 3 years, 5 years, what do you think will be fundamentally different in the way we deliver cataract care, or in the way patients are empowered, or in the way it is financed from where we are today? If we were to predict one thing that is fundamentally different in a few years' time, what would that be? And maybe, Brian, we start with you from from a procurement perspective.
No, I do believe that in the next 3 years, so that we will move towards VBP. I think I'm seeing it now in England, where people are beginning to understand the need for change. So I do think we're going to be in a position whereby we'll be able to work again with clinicians in partnership, and we can actually deliver true value-based contracts. That would be my view.
Okay, so value-based procurement will become the norm. Dr. Castillón, what's your prediction?
I don't really know. It doesn't look good to me right now. But if I have to be optimistic, which I think everyone will ask more things out of our surgery, like coming out without glasses. Mm-hmm. That will be something that they will be asking. They are asking now, but all of them in the next future.
Yes. And Johanna, this speaks to your point about the more empowered patient and more demanding patient as well. And Professor Lorenzo, from your side.
I believe that there will be two big changes. One is how the payers relate with providers. Also, how providers organize the care, and actually the possibility of the patient to see what is the best provider and to select it. And I believe that empowerment of the patient will be something that any provider will need to focus on. If not, bankruptcy is in 1 year or two, 3 or 4.
On that cheerful note, we're going to have to wrap up this session. Thank you very much for your participation.